Okay. So, good evening and a very welcome to one and all. We welcome you to the last session of the Wednesday special thyroid clinics organized by the Indian. So, definitely, thyroid clinics has allowed the residents and the practitioners to learn and discover the ways to improve the patient care and effectively manage a patient with thyroid dysfunction in the ever-changing landscape of medicine. So, before we start, let us first go through the journey of ITS. So ITS has been established, established and registered in 2003. It is a national body of healthcare professionals who with special interest in thyroid disorders. Endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons are part of the ITS. ITS is a member of the Asia Oceania Thyroid Association, that is the IOTA. It has currently nearly 2,000 members. So the founder president of the ITS is also in the executive committee. We have, can we go to the next slide, Asmita? So also in the present executive committee, we have Dr. Professor Pramila Kalra Madam, scientific chair, Dr. Arun Menon sir, who is the secretary of Indian Thyroid Society, and the treasurer, Dr. Miniji Pillai ma'am. The past president, Dr. Rajesh Ratput sir, is also a member of the executive committee. So Dr. Himakirish K. Rao sir is the vice president. The scientific committee coordinator, as I mentioned previously, Dr. Pramila Kalra madam, and joint secretary is Dr. Sujay Ghosh sir. So also Dr. Shashank Joshi sir and Dr. P.K. Jabbasa and Dr. Krishna Sheshadri sir are members of the executive committee. Dr. Mohammad Riaz, Dr. Sushil Gupta, and Dr. Ashraf Jaini sir are also members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, education and awareness about thyroid disorders, to encourage research in thyroidology, to encourage publication of the flagship journal, that is Thyroid Research and Practice, and to have state-of-the-art publications, and to award fellowship of the society, and to encourage membership of the society as well. So, multiple academic activities are organized by the Indian Thyroid Society. Some of the ongoing academic activities are the CMEs, the updates, the symposia, and the conferences. Also, the thyroid clinics, which were initially held weekly and now being held fortnightly, have multiple topics. Multiple topics are being discussed under the following headings: that is the journal club, the case conversations, the monologue, the dialogue. We have the panel discussion, the meet the professor session, the quiz, the workshop, as well as the CPCs. So multiple programs are also undertaken by the Indian Thyroid Society. The Thyroid Awareness Week was celebrated between May 22nd to May 28th. Also the World Thyroid Day on May 25th. And the Thyroid Awareness Month is celebrated annually in the month of January. Also, multiple research activities are being undertaken by the Indian Thyroid Society. Some of them are the ITS provides annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. The research grants are available. To apply for the research grants, it can be accessed through the website, that is the www.indianthyroidsociety.in. Coming to the flagship journal of the Indian Thyroid Society, that is the Thyroid Research and Practice. It is published twice a year, both in print and online. It has a quick turnaround time. Electronic copies are also available ahead of print. So coming to the fellowship of the Indian Thyroid Society, it is basically awarded to the ITS members who have expertise and experience in the field of thyroidology. So it will be selected based on an expert panel. The eligible members will be conferred the fellow of the Indian Thyroid Society. So multiple publications have been have come out of the Indian Thyroid Society. One of it is the ITS Clinical Manual of Thyroid Disorders, the first edition, the editor of which is Professor Avi Jaikumar sir. Multiple guidelines have also been published, which include thyroid dysfunction in pregnancy, guidelines for the management of thyroid dysfunction during pregnancy, and also hypothyroidism and diabetes. The other publications, other guidelines include the management of subclinical hypothyroidism, and also management of dyslipidemia and thyroid dysfunction, and also management of depression and thyroid dysfunction. Also, there are multiple upcoming publications by the Indian Thyroid Society, which include the ITS Clinical Textbook of Thyroid Disorders. The chief editors are Dr. Professor Sarita Bajaj Madam and Dr. Rajesh Ratput sir. Also, upcoming guidelines in the year 2022 and 2023 include management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, and also management of thyroid carcinoma. So Indian Thyroid Society can be accessed through the following website, that is the www.indianthyroidsociety.in. The contents include the link to guidelines, access to the ITS journals and records of all the academic events, including the quiz, as well as online membership portal also. So to apply for the Indian Thyroid Society, the membership, all MCI registered modern medical practitioners in India, they are eligible to become life members. There are two types of life membership available. The amount of membership is about 2,950 rupees. For the full-time life membership is basically given to those who are specialized in the field of endocrinology, endocrine surgery, and nuclear medicine, whereas associate life membership is given to all the other registered medical practitioners. So the applications are invited for the membership online on the ITS website. The details can be accessed through the following link, that is the indianthyroidsociety.in. So before we start, let us then go through the conveners who are responsible for the thyroid clinics, which is being conducted every fortnightly. So basically, the Indian Thyroid Society webinar has been successfully conducted under the leadership of the foremost eminent and distinguished conveners, Professor Sarita Bajaj Madam, who is the president of ITS, Dr. Pramila Kalra Madam, who is the scientific chair of ITS, Dr. Mini G. Pillai Ma'am, who has been the treasurer, and Dr. Arun Menon sir, who is the secretary of ITS. So today evening, being the last session, we have the thyroid ultrasound workshop. The session is being chaired by none other than our eminent secretary, Dr. Arun Menon sir. And we have our esteemed professor, Dr. Neelaveni ma'am, who is the moderator. The quiz as well as ultrasound workshop is being conducted jointly by the acclaimed distinguished dignitaries, Dr. Krishna J. Shadri sir, as well as Dr. Gokul Krishnan sir. So we will start off with the session with the introduction of the chairperson, Dr. Arun Menon sir. So Dr. Arun Menon sir is presently the senior consultant endocrinologist in the Department of Endocrinology at Lissi Hospital, Kochi. Sir has has done his MD General Medicine and DM Endocrinology. Sir also has FRCP as well as CCT Endo to his credit. Sir was previously the professor of the Department of Endocrinology in Amrita Institute of Medical Sciences in Kochi between 2011 to 2020. So the various positions held by Sir include, Sir has been presently the Secretary of Indian Thyroid Society. Sir was the regional faculty of the PHFI Diabetes Mellitus module between 2015 to 2020. Sir was also the PHFI Diabetes regional faculty for diabetic retinopathy between 2017 to 2020. Sir has been the founder secretary of PACE Kerala between 2013 to 2016. Sir also was the secretary of Sendos Kerala between 2016 to 20. Sir was the joint secretary of IMA Kochi between 2016 to 2019. Sir has been the scientific committee coordinator of IMA Kochi as well. And Sir has also been the editor of the JCP IMA online module as well. So over to you, sir, to introduce the moderator.
Thank you, Dr. Gan. Am I audible? There's an echo.
There's an echo. There's an echo.
Okay, let me just.
Good evening, madam.
Good evening. Good evening,
Yeah.
Neelaveni.
Yeah, good evening. Nice to see you after a long time.
Yeah.
Right.
Am I audible?
Yes, you are.
Thank you, Dr. Ganvi. You have been instrumental in getting this program done so wonderfully over the last last few months. So special applause to Dr. Ganvi for having coordinated all these meetings. Thank you so much. Good evening to everyone. Good evening, Sarita ma'am, Pramila, the speakers, and the moderator, ma'am. I'll introduce her in a moment. We have an exciting session today, slightly different from what we have been doing so far. However, this, I'm sure, is a very, very important topic. So although we have called it as a thyroid ultrasound workshop, I think clearly this is a workshop needs to be more hands-on, as we all very well know. However, it's a very, very important topic for endocrinologists, as well as physicians and all thyroidologists who are dealing with ultrasound reports. So I think things have moved on, and in terms of even interpreting an ultrasound report and talking about thyroid ultrasound, you need a certain level of knowledge, and you need to understand the terminologies that's being used. So, we have an excellent faculty today to to tell us about all that. My job actually would be to introduce our moderator for this evening, Dr. Neelaveni. So, Professor Neelaveni is currently a professor of the Department of Endocrinology at Osmania Medical College, Hyderabad. Her area of interest are thyroid disorders in pregnancy, diabetes in pregnancy, and PCOS. As you can see, she has been a member of the Scientific Advisory Committee of the National Institute of Nutrition and ICMR. It's a very important kind of advisory committee. And she's a member of all important endocrine societies, and she has been a teaching faculty for IMA programs as well as PHFI. She has also been an investigator for many trials, both SPI and OPI. Over to you, ma'am, to take this session forward.
Thank you, Dr. Arun. And good evening. Am I audible? My voice is clear?
Yes.
Right. Good evening, everyone. Dr. Sarita, Dr. Pramila, Dr. Mini, like after a long time, actually. So nice, madam. Congratulations to all of you. I think wonderful sessions, and our students are like very much enjoying the thyroid lessons. They are very eager to participate in the thyroid clinics, actually. So, and thank you for giving me this opportunity to be a part of this thyroid clinic program also. And coming to my job today, I think we are going to have an exciting session on the ultrasonography, which is an important imaging modality in the evaluation of thyroid disorders, and especially with respect to the thyroid nodules. So we are going to have a wonderful discussion with the esteemed faculty, which like my job is to introduce the faculty who are going to discuss and enlighten us on the ultrasonography in the evaluation of the thyroid disorders. So the first speaker, Dr. Krishna Seshadri. So it's a great pleasure to introduce Dr. Krishna Seshadri, who is known to all of us and who is a great speaker. So, and he's going to, and the other speaker, and he's a, Dr. Seshadri is a senior consultant endocrinologist at Apollo Hospital, Chennai, and former professor in the Department of Endocrinology, Sri Ramachandra Medical College and Research Institute, Chennai. In 2005, and he's American board certified in endocrinology, diabetes, and the metabolism, and past secretary of Endocrine Society of India. So welcome to you, sir. And the another speaker is again esteemed faculty from the Department of Radiology, Dr. Gokula Krishnan, and currently professor and senior consultant radiologist, Department of Radiology and Imaging Sciences from Sri Ramachandra Institute of Higher Education and Research Institute, Chennai. And he has almost 16 publications in areas of interest are PET, CT, and cancer imaging and image-guided interventions. Over to you, both the speakers, to enlighten us on the ultrasonography. Thank you.
Thank you. Thank you very much, Dr. Neelaveni. Great to see you after many years, and thanks to the Indian Thyroid Society. The one thing missing in my CV, is my relationship with the Indian Thyroid Society. I'm the editor-in-chief of the Indian Thyroid Society's journal, and just to introduce you to the journal, it comes the print version comes 3 times a year. but we are always we are one of the fastest turnaround times, and we are AOP, meaning that the moment we are ahead of print on for every article. So please consider with Dr. Bajaj's permission, let me plug the journal. Please consider this journal as a vehicle for your research. We are good people to publish with.
Right.
Having
Thank
said that, I'm going to, there is a reason for my interest in nodules. And there's a reason for Gokul Krishnan's interest in nodules, and that is me. Right. So many years ago, my mentor, Dr. Chuck Cannon, called me aside and said, Krishna, why is it that you're not why isn't that you're not doing the FNACs, right? And from then on, and then he had gotten a little syringe pump for me, and then every Wednesday we would set up all the FNACs and go and do it. And I'm talking about 25 years ago. And just the feel of the nodules and trying to help these patients who are otherwise undergoing surgery got me an interest into it. The second reason was I've always been a person to whom people would give topics that nobody else wanted. This is my history in the Endocrine Society of India, starting from Dr. Menon in Mumbai. And then, of course, Prasanna Kumar, who first, I think I was the first person to speak on lymphocytic hypophysitis in the Endocrine Society of India when nobody talked about it. I was asked to talk about MRI findings in hypoglycemia. So each year, the one that nobody wanted came to me. And it is interesting because these became areas that people started developing. And that's how my interest in inflammation came. That's how my interest in clocks came. But at some point of time, I was called aside by the patron of the ITS, Dr. Prasanna Kumar, and said, you know what, I think it's time that you started putting your work in one area. And he said, what is that area? I said, I like nodules. And because nobody else wanted it and nobody else was interested in it, that became my area of interest. When I first started doing nodules, we were doing blind FNACs. Ultrasound was not a big thing at that point of time. But since 2000 and 2001 especially, the ultrasound became a very, very important tool in our armamentarium. So from that point of time, we used to get the ultrasounds, but only did blind FNACs. Till this man walked into my life. Gokul Krishnan was a postgraduate and then a junior faculty at Ramchandra. And since he was junior and everybody was on top of him, he got bullied into that. And because I had spoken to the HOD of radiology and said, look, I want to do I will continue to do all my FNACs. I'm not going to allow you to do my FNACs, but I'll be happy to do it along with the radiologist. So that's how Gokul got into it. But the nice thing was, we got to use the state-of-the-art ultrasound. And we know from the past 20 years how ultrasound has changed the way we do this. To the point today that ultrasound, in many ways, is even better than an FNAC. I'm going to stick my neck out and do it. But the work that Gokul and I have done is very phenomenal because we were one of the first in the country to publish that 100% of Bethesda 2 lesions conform with Thyroid 2 lesions. Gokul will remember Gomati et al. That was first published as an abstract. Then we started publishing that work. Gokul's interest was elastography, and I think he's going to show some of his new data with elastography. Then slowly we started adopting to Thyroid 2. Then over a period of time we've been doing a lot of work, and then we did our work on red proton cochain, which is 2013, 2014. And I moved on from Ramchandra, and I still do my work. I do all my ultrasounds. I do all my FNACs. I learned from pathologists how to read cytology. The reason I'm giving you this history is not to tell you what I am. The reason is I'm trying to tell you two things to tell you. One, take one, even if you have interest in everything, and this is for the younger people, take one area and live on with it. So I'm almost certain that even today, if somebody has to write nodules, maybe people will still call either Sujoy or me. So one of the two. And then, that's nice. But there are other people who have already started doing it very well, for example. But what I would love for us, our trainees, to learn is, I know the PNMT Act is there. You can't get a license to do an ultrasound, but go and stand there and learn it today. And we can discuss this today. We'll talk about AI and all the others. But the ultrasound is an extension of the endocrinologist's hand. This is one first part. Second, there was a time when we started that every nodule would go for surgery. I just looked at our own data. Almost none of our nodules go for surgery. Even our Tyrax 3, they get, and the Bethesda 3, we get, and we can talk about it. And I don't want this to be a monologue here. Please interrupt us anytime during this whole presentation. And I will also pitch in with Gokul. I'll let Gokul lead the show, but I'll pitch in wherever. But I think the important thing is that this is an endocrinologist's territory. That it's something that we need to claim, learn to do FNACs, learn to use ultrasounds, learn to know when to take care of it, learn when to get surgeries. Soon we will have Afirma and other markers coming into the country. But even then, and I tell you, I just wrote, Dr. Bajaj knows that I wrote a 12,000 word manuscript for the ITS, and she's still cursing me. But if you read the manuscript, you would see that how the ultrasound is such an important part of what we do. So with that, first let me say how proud I am to see Gokul become a professor and do this workshop. And as a proud mentor, I'm going to see him do this, and of course, interrupt him and make his life miserable. Thank you, Gokul. This is all yours.
Yeah, thank you so much, sir, for that very elaborate introduction. And I'm very glad to join you today along with other expert panelists. And my sincere thanks to Indian Thyroid Society, Dr. Sarita Bajaj ma'am, Dr. Krishna Sheshadri sir, Dr. Arun Menon sir, Dr. Mini Pillai ma'am, and Dr. Pramila ma'am, and all other delegates who joined this program. So 10 years ago, as sir told, we met, and then we started doing all the cases. Sir started giving all his cases confidently to me, even though I was a junior, and then that's how I started to gain expertise in this thyroid nodules. So it was a mutual benefit we both had together. And during that time, our ultrasound radiology HOD was also an ultrasound specialist, Dr. Venkatasai, and he used to give us a very high-end machine, which used to have elastography almost 8-9 years ago itself in our institution. So, so now coming to the quiz session. So I'll be projecting the questions, and I'll be sharing my slide. And each question, how much time shall I give, sir? 1 minute for each question, or?
Not more than 10 seconds.
Not more than 10 seconds. Okay, right. Okay. So then,
max 15. Max 15 if you think the question needs that much time.
Okay, some ultrasound images may be there. Maximum I'll give 10 to 15 seconds.
Yes,
then at the end of the 10 questions, we'll have a discussion about the answers, correct answers.
No, we will have the discussion after the workshop.
After the work. Okay, right. Okay.
Because the IT team needs time to collate the answers and, who have performed well, etc. So, like grading 1, 2, 3. So if that's agreeable,
Sure.
Ma'am, it's all yours. We are good with whatever direction.
Hello.
Yeah.
Yeah. I'll 1 minute. I'll share my
just 1 second. Asmita, you want to say something?
Yes, ma'am. Can we start with the dummy questions, and we'll then go with the actual quiz?
Yeah. So Ganvi, take over, please, and then So Ganvi will just go through the requirements before we start the quiz, and then we're on to the quiz.
Before we start with the actual quiz, we will first have the dummy questions and the quiz participation. So to participate in the quiz, having a Zoom app on your mobile device or laptop. I use a laptop for the ease of experience. The quiz will run about 10 dummy questions followed by the actual quiz. The quiz master will or the description of the question by screen sharing a PowerPoint file The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions has to be submitted at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So we should have the dummy questions now. So the first dummy question: in which city is Taj Mahal located? Option A, Chennai. Option B, Mumbai. Option C, Agra. And option D, Bangalore. Going over to the second dummy question: how many oceans are there? Option A, 8. Option B, 5. Option C, 6. And option D, 7. So hope all the participants could log in their answers. So over to you, sir, to start the quiz.
सीट का हाइट बढ़ाना या कम करना? सीट का हाइट बढ़ाना या कम करना? कम करना।
Gokul, are you speaking or?
Hello, sir.
Ganavi, are you go ahead with the quiz.
Yeah.
I know.
My slide is visible, sir.
So just do it in the if you see the poll is already there, you can just read that.
Okay. So is my slide visible there, sir?
Yes, Gokul,
Yeah,
but you
visible.
don't need to use the slides. It is already in the polls and quizzes. Just open up the polls. But you can go ahead and read it from the slides also. It's not a problem. Go ahead.
Because images are there, sir.
Okay. Go ahead and use it.
Okay. So question 1: what is the needle size preferable for doing a thyroid FNAC? Option A, 18 gauge. Option B, 20 gauge. Option C, 22. And option D, 24 gauge. Your time starts now. We go into the second question now. What is true regarding the consistency of a nodule? Option A, hard nodules are more likely to be benign. Option B, soft nodules are more likely to be malignant. Option C, hard nodules are more likely to be malignant. Option D, cystic nodules are more likely to be malignant. We are moving to the next question, third question. So you can, if you're able to view the image, you can see it. How do you comment on the echogenicity of the nodule? Can you please describe what is the echogenicity of this nodule? Option A, marked hypoechoic nodule. Option B, hyperechoic nodule. Option C, isoechoic. Option D, hyperechoic. How do you describe this nodule? Last 5 seconds for this question. Then we move to the next. Going to the next question, question number 4. What is the shape of this nodule? How do you describe the shape of this nodule? Option A, not taller than wider. Option B, taller than wider. Option C, wider than taller. Option D, neither taller nor wider. Move on to the next question, fifth question. How do you interpret this ultrasound thyroid as? Option A, multinodular goiter. Option B, true nodule. Option C, pseudonodules. Option D, thyroid lymphoma. We now move on to the next question. Sixth question. Which of these nodules do not warrant thyroid FNAC? Option A, thyroids 1 and 2 nodules. Option B, thyroids 2 and 3. Option C, thyroids 3 and 4. Option D, thyroids 4 and 5. Which of these nodules do not warrant FNAC? Now we go to the next question. Question number 7. How do you name this artifact? There's an artifact in the ultrasound. How do you name this artifact? It is marked. The clue to that question is it is marked. So this is the artifact. Option A, is it a comet tail artifact? Option B, ring down artifact. Option C, posterior acoustic shadowing. Option D, posterior acoustic enhancement. Okay, now go to the 8th question. What is the name of this imaging technique? Option A, shear wave elastography. Option B, strain elastography. Option C, micropure imaging. Option C, microvascular Doppler. Going to the 9th question now. What are the key points while assessing a thyroid nodule for malignancy? Option A, composition, echogenicity, margins, calcification, shape. Option B, composition, vascularity, margins, calcifications. Option C, vascularity, echogenicity, margins, calcification, and shape. Option D, composition, vascularity, echogenicity, shape, and margins. Which one of these is true? Last 5 seconds. Last question. What is the name of this imaging technique known as? Option A, shear wave elastography. Option B, strain elastography. Option C, micropure imaging. Option D, microvascular Doppler. Yeah, that is the end of 10 questions now. So we have the discussion for all these quiz questions at the end of our lecture.
Thank you, sir. So now we shall proceed to the workshop on thyroid ultrasound. So over to Gokul Krishnan sir and Krishna Jeshwadri sir for the workshop.
Krishna sir is there? Shall I go ahead, sir?
Yeah, you're the main discussant. You can go ahead.
Please.
Okay.
Yes,
Okay.
please go ahead.
Okay. So, good evening, one and all. Today's topic for discussion is ultrasound imaging of thyroid nodules.
Gokul, proceed. I couldn't hear you. Go ahead.
Yes, sir. Yes, sir. 1 minute, sir. Okay. Am I audible, sir? Am I audible?
Yes, you are. Yes, you are.
Oh, yeah. Okay. So now we are going to see how to approach a thyroid nodule in a step-by-step pattern. So this topic has been broadly divided into 5 segments. First, we are going to see the introduction of thyroid nodules. Secondly, we are going to see what are the 5 key points to assess or look for while categorizing the nodule as a benign or malignant. And thirdly, we are going to see what is the correlation between thyroids and Bethesda from our experience. And fourthly, we are going to see what is the role of elastography, that is the recent advances in thyroid imaging in evaluating the thyroid nodules. And finally, we are going to wind up the session by materials and methods for doing the FNSC of thyroid nodule. First, going on to the introduction, we need to be very familiar with what is actually a thyroid nodule is. Many times, we take the pseudonodule as thyroid. It is one of the common error in interpretation for a radiologist, especially young people when they come. So they misinterpret pseudonodule as thyroids, which are okay. So the definition of thyroid is nothing but thyroid nodule is defined as discrete lesion within the thyroid gland that is radiologically distinct from the surrounding thyroid parenchyma. For example, in the first image, this is a thyroid nodule which is distinctly visualized from the thyroid parenchyma. It has a nice wall all around it. It is separately seen. It is a discrete nodule. Whereas if you take this example, people tend, especially young people who are starting to report thyroid nodules, they may tend to give it as a multinodular goiter, but this is not a multinodular goiter. This is a pseudonodule because of thyroiditis. There's no perceptible wall. It looks like a multiple nodular goiter, but it's not, because there's no perceptible wall all around it. It's not a discrete lesion. So that differentiation you should be able to make while interpreting thyroid nodules. So this is a true nodule. This is the pseudonodule, which is most commonly seen in case of thyroiditis. As we all know, the incidence of thyroid nodule is more common in women than men, and the prevalence increases proportional to the age. And by using a hand for palpation of thyroid nodules, only 4 to 7% of thyroid nodules were picked up as per literature. But when we started using high resolution ultrasound, the incidence of picking up thyroid nodule increased many-fold, up from 20 to 76%. That's a very great increase in number of thyroid nodules. So most of them were incidentalomas and they are benign. And hence the ultrasound is called as a clinician's third eye. And the worldwide prevalence for thyroid malignancy is only 4 to 6.5%. The expansion of thyroids is nothing but thyroid imaging, reporting, and data system. Thyroid imaging, reporting, and data system. It was proposed initially by Howard et al. In 2009. And the main aim was to risk stratification, to stratify the risk, which is similar to BIRADS, which is used in breast imaging, reporting, and data system. It was already existing, similar classification was there, which we adapted for thyroid nodule. And the purpose was to unify the language between the referring consultant and the radiologist. So now going to the second segment of sir. Yes, sir.
Can we have a quick discussion? Yeah. So one is, can I ask you? So people who use multiple probes, right?
Sorry, your voice is breaking. Sir, I'm not.
One second. So in what probe is used for the thyroid? So there are many probes, right? Can I use a abdominal probe for the thyroid?
Linear probe, sir. Linear probe, high frequency probe, 10 megahertz we are using, sir, currently.
That is a probe that you.
Yeah, linear probe, 10 megahertz, high frequency probe.
Right. Just to also make a comment that, that while Howard talked about thyroids, the original work for thyroids was actually done in Korea. And the first publications were also there in Korea. So, but Howard is the one the English language literature looks at. Many times we don't look east, but a lot of work is, in fact, one of the best. I don't know, you and I had this discussion before that the K thyroids is probably one of the best in the world. But now I think the ACR thyroids has really done a lot more. Thank you. Is there any other questions in this segment? We'll be happy to take because it's a workshop. I don't want to move all the questions to the end. If someone has a questions about what Gokul has talked about, yeah.
And for pediatric age group, like, do you have any different probes, or the same thing can be used for the pediatric age group?
There's a probe called for a neonatal, it may be required, ma'am. For a pediatric, I think it would be sufficient for more than 2 years, 3 years and all. This linear probe would be sufficient. But there's a probe called hockey stick probe for a neonate. If you want to check for a neonate whether thyroid gland is there or not, that is even more a higher frequency. That will be useful, ma'am. That is used commonly for musculoskeletal purpose, but that can be substituted for looking for any neonatal congenital absence of thyroid gland or not. Hockey stick probe.
Okay. Any other questions that are burning? Otherwise, we let Gokul continue.
Let's talk on the little positioning for the proper imaging of the thyroid gland. How should we keep the positioning, at least for the beginners who are interested to learn about the thyroid ultrasound? So, is there any particular position like where like we look at both the lobes and like?
Yes, ma'am. In my subsequent slide, I'll be explaining.
Okay. Are we going to discuss, right?
Yes.
Thank you.
Go ahead, Gokul.
So going to the next segment, what are the 5 key points to assess the nature of the thyroid nodules? So the main heading is composition. When you describe a person as a nice person, so we should explain how good he is, how he's behaving to others, how courteous. So similarly, for a thyroid nodule, there are different characteristics, features we should look for, and finally come to a conclusion whether that nodule is a good one or a bad one. Good one in the sense benign or a malignant. So these are the 5 key factors which we normally look for evaluating a thyroids. One is composition. Second is echogenicity of the nodule. Third one is the margins, calcifications, and finally the shape. So this is a broad outline. There's a flow chart which is taken from ACR, American College of Radiology white paper in 2017. And so composition, these are the 5 elements: composition, echogenicity, shape, margins, and echogenic foci. There are different point systems under each headings, which we will be seeing in subsequent slides, and we get a sum of all the points, and finally it will be assigned some particular scoring. So based on the scoring, we will be calling whether the nodule, whether it's a thyroids 1 or up to thyroids 5. So the most important thing, one of the take-home points is that thyroids 1 and 2 will suggest no FNEC, whereas between thyroids 3 and 5 they suggest FNEC depending upon the size of the nodule. Now, going to the first characteristic point for assessing the thyroid nodule, that is the composition. So composition, there are 5 different types. The first one is purely cystic. Second one is a spongiform. Spongiform in the sense the cystic spaces should be more than 50% of the nodule. If a nodule is there, if it is solid and cystic, the cystic spaces should be more than 50% to call it as a spongiform nodule. Third one is mixed solid and cystic, which will be given 1 point. Here the criteria is that the nodule should be more than 50% solid but less than 95% solid. Okay, between 50 to 95% solid will be called as mixed cystic and solid nodule, which will be given 1 point. And the fourth one is a solid, completely solid or almost solid, that is more than 95% of the nodule is solid, that will be given 2 points. So generally, if the nodule is more and more solid, it is more and more chances of malignancy. More and more chance, if it is towards a cystic, more if it is a nodule is more cystic, more towards, we are tending towards benign nodule. That is a broad outline. And there's a final one category called can't tell category. You can't say it because of the calcifications. There is a posterior acoustic shadowing, and you're not able to characterize a nodule because of the shadowing. We call it as artifact posterior acoustic shadowing. And if you encounter such nodule, then we'll give 2 points. Okay, so this is a pictorial assay of whatever I was talking in the previous slide. So this is an example of purely cystic nodule. There's no solid component at all, which is anechoic nodule. We'll call it as anechoic nodule. There's no solid component at all. So that will be, this is the least chance of malignancy. Okay. Second one is the mostly cystic nodule. This is a spongiform nodule. More than 50% of the nodule is cystic, and this also given 0 points. These two nodules are least chance of malignancy. Okay, and next criteria is mostly solid. That is a nodule which is 50 to 95% solid. It will be given 1 point. This is an example. If the nodule is more than 50% of the composition of the nodule is more than 50% solid, then but less than 95%. And here the nodule is almost solid. That will be given. That is more than 95% solid, which is given 2 points. And finally, can't say category, because I told you as a classification, obscuring, we are not able to assess correctly the nature of the nodule. So in that case, we can give 2 points. This is the eggshell pattern of classification, eggshell appearance. Okay, so that is causing posterior acoustic shadowing, and we are not able to see the characters and nodule properly. So this is the composition.
So Gokul, just to interrupt you here and clarify it. So if you look at this last thing, can't say.
Yes.
Normally, we are looking at it and thinking about it as somebody like me who doesn't know as much about you as ultrasound would think that this is fluid, but actually it is not fluid. But the high intensity, I mean that the calcification is reflecting all the ultrasound, and therefore behind it there is a shadow. So this is not fluid, but this thing, is that correct?
Yes, sir. So this is a completely fluid one, sir. So it will cause posterior acoustic enhancement. For example, this area is bright. If it is a completely fluid, it will cause posterior acoustic enhancement, opposite of whatever you are seeing in calcification, because it is not reflecting back all the sound which is given. It transmits all the sound passing through it. So here this region will enhance. This is posterior acoustic enhancement. Here this dense calcification is there. It reflects back or whatever the ultrasound towards the transducer towards it. So there's no ultrasound passing through that. So we get a shadowing. So because of the dense nature of the calcification. So this is posterior acoustic shadowing in case of calcification. This is a completely cystic nodule. And that's it.
Go ahead, Gokul.
Okay, now going on to the second key point, the echogenicity. Regarding the echogenicity of the nodule, we need to compare the echogenicity of the nodule in relation to two structures. One is the strap muscles of the neck and the ipsilateral thyroid gland. So we need to compare the echogenicity with the strap muscle of the neck as well as the ipsilateral thyroid gland. So here anechoic will be given 0 points. If the nodule is hyperechoic, that is bright, or isoechoic, same as that of the adjacent structures, it will be given 1 point. If it is hypoechoic, it will be given 2 points. That means the nodule is less echogenic than the thyroid points. We will call markedly hypoechoic or very hypoechoic if the nodule is less echogenic than the thyroid as well as strap muscles. So then here we give 3 points for that. And finally, there's a category called can't tell category that will be given 2 points because of the calcification. Here the example of each. So this is a completely cystic nodule. It is anechoic nodule, which is given 0 points. And this is a hyperechoic nodule. This nodule is brighter than this is a surrounding thyroid parenchyma. This is brighter than the adjacent strap muscle. This is a strap muscle of the neck, and this is the upper lobe parenchyma of the thyroid. So it is brighter than that. This is hyperechoic, which is given only 1 point. When we go to the next slide, we are seeing this is isoechoic nodule. This is a thyroid nodule, and it has same echogenicity that of the adjacent thyroid parenchyma as well as the strap muscle. So that is given only 1 point. When we come down here, this nodule is hypoechoic in relation to the adjacent thyroid parenchyma, and but it is slightly brighter than the strap muscle of the neck. So it is given 2 points. It is called hypoechoic nodule. Now very hypoechoic nodule or marked hypoechogenicity of the than the adjacent thyroid parenchyma as well as the strap muscle of the neck. So I hope you can able to appreciate the echogenicity difference in all these slides. And this is a final category called Contel category. Because of the dense calcification causing posterior acoustic shadowing, I'm not able to characterize this nodule properly. So here we can give 2 points. Okay. Any doubts in echogenicity of the nodule? Can I go ahead, sir?
Gokul, go ahead, and once we finish this section, we can have a small discussion.
Okay, okay, sir. Key points. Then the third one is the margins. How is the margins of the nodule? For example, this nodule has a completely well-defined peripheral halo. I am able to see a dark lucency around it. Okay, this margin is a complete lucency is there, and this is given 0 points, smooth margins. And this is another nodule which is having a slightly ill-defined margins. The margins are not sharp, slightly ill-defined, but most of the periphery I'm able to pick it up, but except in the edges I'm not able to see the margins clearly. So for example, this region is slightly ill-defined. This nodule is well-defined. Both these things are given 0 points, least chance of malignancy. So when you come to see this nodule, it is having irregular or jagged margins, which is given 2 points. You see this outline of this thyroid nodule, irregular jagged margins. Okay. Then there is another nodule called as lobulated margins. You can see this is called macrolobulated appearance, lobulated margins. This is called as microlobulated margins. So these nodules are given 2 points. Coming to the fourth key point in assessing a thyroid nodule is the nodule is taller than wider. If the nodule is wider, if it is wider than taller, or if the width and height are same, then it will be given 0 points. And if the nodule is taller than wider, it is given 3 points. So more chance of malignancy. This nodule tends to grow against the normal tissue plane. That's why it is given 3 points. Going to the final characteristic of the nodule, shape of the nodule. You can, for this example, you can see this nodule is wider. This is wider, 0.8 centimeters, and the height is 0.6 centimeters. This is wider than taller. So this is given 0 points. You can see this is equal length and width. So it is given 0 points. 1.2 centimeters is the height and 0.8 centimeters is the width. So this is given 3 points. So this kind of nodule tend to be more malignant. Coming to the fifth point, echogenic foci or calcifications. If there is no calcifications, it is 0 points. Macrocalcification, it needs to have posterior acoustic shadowing. Then only we'll call it as macrocalcification. So then we have another pattern called as peripheral calcification of points. Then the last one is punctate echogenic foci. Tiny dots are given 3 points, and there should not be in the criteria is that it should not cause any posterior acoustic shadowing. It should be very small, miliary kind of appearance will be there, calcifications will be there, and it will not cause any shadowing. That is more chances of malignancy. Now, this is the image pictorial representation of these, whatever I described. This is a macro calcification which is causing posterior acoustic shadowing. These are the artifacts. So that is given one eggshell pattern of calcification, not allowing the ultrasound waves to pass through beyond that. It is causing a dense dark shadow. So that is given 2 points. This is the artifact which we are talking about. Common tail artifact. This is a common tail artifact. For example, there is a punctate calcifications are there. but it is causing a small stripe, linear stripe beyond that. So this is called a comatary artifact. It is given 3 points. And finally, whenever you are seeing
Gokul, the artifact. Gokul, the
Yes, sir.
artifact is not given any points. It's only the microcalcifications, correct? The comatary artifact is ignored.
Microcalcification. Microcalcification. Yeah, this you can look forward, sir. Like yes, you can ignore it, but this artifact you can see it.
Along the thing, right? The comatary artifact is not given any points.
Yeah. This is a punctate calcification, so most important. But you can recognize this if you are seeing it time and again, you can recognize it. And microcalcifications and macrocalcifications, when both are there, you can combine both the points, 3 plus 1, and totally you can give 4 points for a same thyroid nodule for calcification alone. So I spoke all the 5 characteristics. So there's a website called thyroidscalculator.com. You can go to that website. You can choose one of the options. For example, composition. You can, out of 4 options, you can choose according to your imaging, your interpretation, and the points will be added. Echogenicity, you can choose one of these 4 options. For margins, you can choose one of these 4 options, and for calcifications, you can choose whatever is applicable in this. And finally, you get a points automatically, and it will suggest your thyroids, whether thyroids 1 to 5, it will give you a range, and it also automatically give you the recommendation what to do next. So that is the end of second session, sir. If you have any questions now?
So Gokul, I think what the first thing that I want to discuss, and please start sending your questions, is one, why is it that we are looking at an ACR thyroids instead of any other classification? Remember, there are many risk stratification scores. We talked about K thyroids, we talked about U thyroids. The British Thyroid Association has its own. Importantly, American Thyroid Association also has its own. Why is it that we are looking at ACR thyroids? Maybe, this I will answer simply because from an endocrinologist perspective, the first thing is that it is better to have a scoring system because in India, endocrinologists cannot report ultrasounds. And definitely, be careful of the PNMT Act. And radiologists are doing most of the ultrasounds. I think the smart thing is to do something that they accept. I think that is one bit. The second thing is to Gokul, can I share my screen 1 second? Can you answer?
Sure, sir.
Because Arun Menon has asked, what is the essential difference? So, for example, Gokul, can you also say, for example, when we started out, we talking about vascularity. Can you unshare? We talked about vascularity. Today, we don't even report vascularity, right?
Okay,
the central vascularity, peripheral vascularity. But in these scores, vascularity is not even important. Why do you think so?
Can you, the IT people, can you help me in unsharing this slide?
It's okay. Don't worry about it. Go ahead and answer that question, and I will just say the points to go. Arun. Yeah. So we don't do things like vascularity anymore, don't we?
Yeah. Yes. Vascularity is not given importance.
So just to Arun, to get your point, there are several differences between this. For example, the ACR thyroid, all of them will look at echogenicity, hypoechogenicity, taller than wide, irregular shape, punctate echogenic foci, right? The ATA does not look at macrocalcifications at all. On the other hand, it has 2 different kinds of calcifications: rim calcification with extrusions and peripheral calcifications. The ACR thyroid looks at invasion of parenchyma. The ATA looks at internodular vascularization. Having said that, what performs better? I think that is the most important question. And the question is, the second difference is the criteria for FNAC. The beauty of the ACR thyroid is it gives a definite score that clearly tells you when it is. On the other hand, the ATA, the U thyroids, the K thyroids, and certainly the British thing, look at benign, very low suspicion, only ballparking. So in many ways, the ACR thyroids is a way of pretty much standardizing reporting, and the interradiology variation is quite low, isn't it, Gokul?
Yes, sir. Yes, definitely.
So
The
in many,
inter-observer error is less.
it is very less with the ACR thyroids. The second thing is to look at in which one of these do you have missed malignancies, and the more importantly, in which of these are you doing the more amount of unnecessary FNACs. Enough amount of meta-analysis have shown that that the ACR thyroids has the least amount of unnecessary biopsies. There are big goods and problems with each of these. And if you're doing something in the past, my suggestion is continue to do it. If you're, for example, doing the BTA FNAC, go ahead and do it. I have adapted, for example, when we started, Gokul and I started, or we started using the regular Howard thyroids. That if you look at our first publications, it was all Howard thyroids.
European.
But nowadays, in 2017, when the white paper came, I switched to ACR thyroids. And one of the interesting things that happened was many people who were on 2 were upgraded to 3. That would happen. But the nice part of it is that the ACR thyroids has specific cutoffs for FNAC. And one criticism has been that, for example, for ACR thyroids 3, ACR thyroids 2, there is no FNAC. For ACR thyroids 3, the FNAC is actually greater than 2.5 centimeters, correct? Some people, for example, in the ATA, it is not, the equivalent is 1.5. But having said that, a lot of unnecessary biopsies are done away with the ACR thyroids, and that's why we use it. Let's quickly answer a couple of questions here before we move on. There are 4 questions in the Q&A box. Someone's asked...
Sir, can I interrupt?
Yes, please. Please.
In this context, like thyroids 3, like more than 1.5 centimeters follow, or is it less than 1.5 centimeters follow-up and more than 2.5 centimeters requires to go for a FNAC? Am I right, sir?
Right. If it is greater than 1.5 centimeters. See, what is it? The new evolution
what is that? That's what I want to know, sir. Like importance of science.
So, for example, if you look at the ATA guidelines and the new revision that is coming out, they are even talking about not an FNA. For a thyroids 2, they are even saying you really don't need to follow up. Many of us are uncomfortable with it, and we still do FNACs, but I've reduced the FNACs to once in 2 years at least. I'm sorry, the ultrasounds to once in 2 years. But what it is an extension saying that patients with thyroids 2 and thyroids 3 of less than 1.5 have such a low risk of this thing that you probably don't have to do yearly or every 6 months follow-up. All of us are uncomfortable with this opinion, but that is what the data is, right? I still follow up. I still do ultrasounds, but I'm still not comfortable with not following up. But this is where the white paper comes in. This is where the new ATA guidelines that are coming out are coming in. So this is right. What is written in the slide is right. That if it is greater than 1.5 centimeters, you look at an annual follow-up. In thyroids 4, greater than 1 centimeter, it's an annual follow-up. In thyroids 5, it is more than 0.5 centimeters, it's an annual follow-up. So clearly, we are talking about a group of people who are low risk, that in these studies, and these are large studies, that they probably don't require follow-up ultrasound on an annual or a semi-annual basis. I am not comfortable with it. I don't follow it, but it is there. So does it answer your question?
Yeah, the message is like, apart from the 5 key components of the ultrasonography, like even the size also matters.
Absolutely. And that is why the ACR thyroids is so good, because it gives you two sets of criteria. One is the score, the absolute score. And I'm sorry, I'm not able to share my screen, but I would have shown you how in our own patients, we use it. In fact, our EMR contains these values. We follow every year. And then we document the volume and the change in the score. But if it is more than 50% increase in volume, or if there's a change in the score, then only we FNAC, otherwise we don't. So I think this is something that we can all learn. Can we quickly answer these other questions? Also, somebody who's got a thyroid 4, if it is more than 1 centimeter, this is to Gopalakrishna Chertala. Somebody who's got thyroid 4 and more than 1 centimeter, or more than 1.5 centimeters, you need an FNAC. This is one. But remember, please be careful. What thyroids are they reporting? Are they reporting a ACR thyroid score? Now, while A, B, and C were reported in olden days, Gokul, can you tell the difference between A, B, and the new ACR thyroid spaces? Why don't you take this question? We don't do this anymore.
You want to discuss the previous one, sir, what we practiced initially?
The four. One of the questions is 4A and B. We don't do that anymore, correct?
Yes, sir. Actually, initially, Thyroids 1, this is a European Thyroids beginning. So, Thyroids 1 was completely normal. There's no nodule at all. That is how they describe it. Thyroids 2 is benign, and 3 is probably benign. 4 is like that. So, 1 was completely benign, completely normal. Thyroids 1 was completely normal as per old classification. But now, ACR 1 is telling that the nodule is there, but it is definitely benign. Like that, some modification is there.
And we don't report 4A and B anymore.
No, 4A. Actually, 4 was divided into A, B, and C.
And C.
With higher risk of, chances of probability of malignancy increases with the A, B, and C categories.
But we don't report it in ACR thyroids anymore, Arun. Okay. Two more questions. We have a case of euthyroid MNG on USG with thyroids 3 and 4. We asked the FNAC callers if it is more cystic, you may not get anything. Actually, that's not correct. And maybe when you do the FNAC, we'll tell you, you can actually take from the border of cyst and solid if it is majority, and you will get. One more interesting thing, I think, Gokul, if you'll remember, is that we used to, if there was a punctate echogenic foci, which is a micro calcification, we would try to actually aspirate from that area, because there has been some studies that showed that these actually, what is it called, coordinated with the owl's eye appearance, or the Annie owl's Annie eyes lesions that you will see in pathology. So there used to be a time when if you see a microcalcification, you would actually FNAC in that particular area.
Yes,
Kashyapa Janabatia, do we calculate cystic component or visually say it's more cystic or spongiform? While the term spongiform means that, it's almost benign and everything talks about it, my suggestion is move away from all these terms. Just start using ACR thyroids 1, 2, 3, and 4. Okay. Any more questions, or can we ask Gokul to continue?
Continue, sir.
Okay. So Sagar Saurabh, just before Gokul starts, I don't even, if it's a Bethesda 2, you don't need to repeat FNA unless there's an increase in size or a change in the thyroids. Okay, go ahead.
So now going to the third segment of this discussion, correlation between thyroids and Bethesda. So this is our publication in Indian Journal of Endocrinology and Metabolism a couple of years ago. So where we followed the older classification, like European thyroids, and we arrived at this is out 184 nodules were sampled, and 117 nodules were given as thyroids 2. And out of these 117, almost all the nodules were falling within Bethesda, between Bethesda 1 and 3. None of the nodules were falling between 4 and 6. That is a malignant category. So this is when we compare with other international studies, it was in line with other international studies were discussed by Howard et al. And Quack and Mafia et al. 2 years ago. So this the risk of malignancy is 0 in our study when it was given thyroids 2. That Bethesda and thyroids has a very good correlation. So as the thyroids 3, 4, and 5, you can see the increasing probability of malignancy in our study. So the take-home point was in our study, it was on 0 for thyroids 1 and 2, the probability of malignancy of nodule in assessing 184 nodules. And so that is about the previous thing. Before, shall we go on to elastography, sir? No?
Yeah, just briefly mention it because. Yeah.
Okay. And elastography is nothing but it is a technique, latest technique, which is used to assess the stiffness of the given tissue which is equivalent to that of the electronic palpation. And in heart, the consistency of the nodule, more chance of being malignancy. So there are two types of elastography: strain elastography and shear wave. Shear wave is the latest one. Strain elastography, you have to give manual compression and take readings, whereas the shear wave elastography, it automatically gives the it uses acoustic radiation force ultrasound impulse, and it gives a quantitative study. It gives a number, whereas this doesn't give any number. Strain elastography doesn't give you any value, but you have to assess with your eyeballs. To color coding will be there, and based on that you can subjectively see whether the nodule is benign or not. For example, this is an example of strain elastography. This is slightly older technique. So here we have to give compression. This wave is nothing but compression and relaxation. Compression and relaxation. Okay, I am giving compression relaxation. So then I'll take images like that. So you can see the color coding. The hard consistency is red, and the soft consistency spectrum is blue. In between that, you have yellow, green, and all. It is all in between. The consistency is firm, but not either hard or completely soft. So, for example, this patient, the nodule was there. If the patient doesn't have any taller than wider, the appearance is not taller than wider, but the margin is slightly, it was not well defined. That is the only one clue was there. But when you put elastography, it was a very hard nodule. You can see that the surrounding parenchyma is all soft, which is green or either in the blue, but the nodule is very hard. So finally it turned out to be a negative FNAC, it turned out to be papillary carcinoma. So we have to visualize subjectively and write it in case of a strain elastography. There's no particular number here. Then this is the example of shear wave elastography. This is a slightly advanced technique where, for example, this nodule, it is taller than wider. It has punctate microcalcifications. When I put a this thing, point of interest region. So the shear wave elastography gives you value. For example, 4 and 5. For example, this value is 4 and 5. Here it gives the value in case of kilopascals. The elasticity is given in case of kilopascals. I have taken region from 9 regions. I have taken the value, and the average value is 106 kilopascals. So as per the literature, anything more than or the vendor, the machine vendor, they suggested they have norms for that. They suggested anything more than 66, you can take it as 66 kilopascal. You can take it as most likely malignant. But here in our case, the mean of all the values is 106. So we assign this as Thyroid 5, and it turned out to be again papillary carcinoma. This is an example of shear wave elastography in assessing a benign nodule, which is for example, this is a spongiform nodule. You can see the nodule is not very dark. It is only bluish color. That is towards a soft consistency. Okay, it gives a visual interpretation as well as the numerical data. I am taking the samples from these regions and gives the value. I have taken 5-6 readings, and the mean elasticity is only 17.6 kilopascal, way below the normal range given by the vendor, by the machine vendor. That is 66. It is way below that value, kilopascal. So it is definitely a soft consistency nodule. So it is giving you the number as well as the visual interpretation. The shear wave has a definite advantage over the manual strain elastography. Okay, so that is in short about elastography.
So two things. One is, remember that it depends on the quality of the machine, because not all of these the same. Do you need to? I think Arun has asked, do you need to do the elastography? I think at this point of time, the world data. Gokul, show your data first.
Yes, sir. And one more before going to the data, one more advantage is that you can choose the region of interest where you want to do FNAC also. So you need to target your more suspicious areas. So not only in assessing the elasticity, the nodule will be heterogeneous. One area will be hard and the other area will be soft. So we don't want to take FNAC from the soft area. So we need to take the FNAC from the correct target. So the correct sampling can be done. So for that also, this elastography is very useful, sampling the correct area. So
So can you first show your data? Where's your data?
Yeah, 1 minute. So this is the data. So here in our, it was a thesis study which was given to one of a PG. She did during the COVID time. So the case number has fallen significantly when you compare with the previous study, but it was only 95. But it is under publication. This is studies under publication. You can see out of 95 nodules, this is thyroids 2, 3, 4, and 5. There's an increasing mean elasticity value. The thyroids 2, the mean elasticity value is 18.2, 34.2, 69.6, 110. So the cutoff was 66, what we kept for our study. So we can see that increasing trend of elasticity, increasing trend of hardness. We can see the kilopascal is increasing here in the y-axis, and this is the x-axis thyroids. So and so this is the cutoff which you kept in the nodule. Out of 95 nodules, 79 were given as, we identified the nodules where 75 were below 66 kilopascal, and 72 were turned out to be benign. So one of the conclusion in our study is that it has a high specificity rate, not the sensitivity. It has a high specificity rate of 92.3 in identifying the true negativity of a nodule. Okay, so it can be useful to rule out a particular disease. It can be used to
rule in, you mean?
Rule out a particular highly specific disease. Can rule out some conditions. So that is the conclusion what we got in our study observation. So
to answer Arun's question, I think it's very important to understand that 95% of your patients will not need a shear wave elastography, right? When do I use it? For example, in a patient who's got, he may have a thyroid 3 and I have done an FNAC, and I get a Bethesda 3 or a Bethesda 4, right? Then this is where it comes. For example, if the Bethesda 3 plus thyroid 4, then I would consider surgery. But we don't have molecular markers readily available. So here, what would I do in an indeterminate nodule? I would relook at the ultrasound and see if there are pointers to go back and have a better person to do a sonology. Second, if just a Bethesda 3, I would just re-aspirate in 2 months. The third is, along with the ultrasound, this is one of those people where I would say, have a very good sonologist like Gokul do, right? If he tells me, sir, the kilopascals is 90 for this, then I would put up my neck and say, you know what, let's go ahead and get the surgery. But the important thing to remember is that even if there's shear or strain, it's very, very radiologist dependent. If you look at the literature also, you'll find very, very, up and down. And that's also because that literature includes a lot of strain wave elastography and not shear wave elastography. Once articles like this come out, I think what will happen is, and remember, I started at the beginning in saying that ultrasound is probably better than molecular markers. Ultrasound is probably better than anything else, other than just a simple cytology in diagnosing thyroid malignancy. And so here, this will become a component. My suggestion is please don't do PET CTs, don't do MRIs, don't do CTs. Let's say tell you all the things that you shouldn't be doing. But shear wave elastography you can do if I would think that you would do it in somebody who's got who has this. So the lowest elasticity was for malignancy was 66, correct, Gokul?
Yes, sir. Yes, sir. So that was suggested in few of the studies, as well as our vendor also, he suggested to keep that cutoff of 66 kilopascal. And so most of the nodules beyond 60.
Well, the question was, there were seven of those less than 66 that became positive, isn't it? Am I right?
Yes, yes. So still there's overlap, but
seven. What was the lowest elasticity? Below what level can we definitely say that yes, that's it?
Even 20 kilopascals also we identified some of the nodules turned out to be. So it is not 100%, but you can go towards so if you have some gray area, either 3 or 4 like that, it will be useful. So even I found some nodule of 20 kilopascals turned out to be malignant out of the
So
7.
that is exactly why elastography is a very, very limited tool that you should do. Despite Gokul's interest in it, I would caution a lot of people not to use it. Again, to say that, remember, look at the sensitivity rate. Even in this small study, it's only 58%. The true positivity is quite low, which means its ability to rule out disease is very poor, right? It may have but exactly that's really what you want. So if in someone who's got an intermediate probability or a higher probability, for example, let us say it's a Thyroid 4 and a Bethesda 4, a positive shear wave elastography will work in the terms of saying, okay, your pretest probability for malignancy is almost going up from, let us say, 60% to 80 to 90%. You can confidently say this, you should send the patient to surgery. So I would sort of relegate elastography to that level and not as a primary decision-making tool, right? And that's where the clinician's thing comes in. And given I'm sticking my neck out and say that in my experience, that it is better left to. It is a very interesting tool, but I don't want any of our viewers to go home with the view that it is a primary screening tool. Okay.
It is a complementary tool to, in addition to whatever the other previous characteristics we saw, it should be combined with other factors also, not as separately. You should not assess only to go with the virus. But in general, it's not 100% correct. But in general, if you get the consistent hard consistency, more chance of malignancy. That sometimes we are not able to see with the digital palpation, we are feeling it properly. So that we have a data, this particular number. So that will help you to tell whether what is the consistency of the nodule. Take it as like that. So don't go only with the number of kilopascals. Okay, this is malignant. It is not like that. If it is hard, then more chance of malignancy. Like that only you have to take it. It's a complementary tool in addition to what the previous B-mode scan criteria are existing.
So Gokul, can you go to the last section, because I think we come.
Yes, last. So there are two techniques while doing a FNAC, in-plane and out-plane technique. So in-plane, you keep the nodule on in the neck in the extended position, and you can see that from the corner or edge of the probe, we are giving the needle, inserting the needle, and you can see the entire length of the needle while we're doing in this technique. Out of plane technique, I go in the middle of the probe, and I can see only the tip of the nodule. There's a short video clip of two techniques.
Hello.
So this is in-plane technique. You can see how the probe is placed on the edge of. Okay, now there's an example of out-of-plane technique.
So while that's going on, just to add that, generally when we do an FNACs, I as an endocrinologist will be working with the radiologist. We do the FNACs, and we also have a cytologist there who can quickly tell us, if the sample is adequate or not. There are criteria for the adequacy, and we do that. The other thing is, a lot of people now have started doing liquid biopsies. that we don't spread on the smear, we don't do any of that, just pour it into the thing. And if you are, and in places where the Afirma and other or Thyrosec or Thyramir are available, they would already take a small sample and keep it separately for Afirma and other this thing. Go ahead, Gokul. We can close up, I think. Okay, while we're going on, let me just answer Srinath's question. Well-defined hyperechoic nodule. And this is previous to FNAC colloid goiter. So the first thing is, relook at the ultrasound. Sometimes, I just look at the picture and then try to get an ACR thyroid score. If it's hyperechoic, the nodule, the margins are fine. There is no punctate echogenic foci. This looks like a type 2, right? And if there is nothing, just leave the patient alone. There are no recommendations to follow, but I do follow them up maybe once in a year and then once in 2 or 3 years. But this would really not require anything else to do.
So this is an example of out of plane technique. You can see where the needle is placed, and you can see the relationship between the needle and the probe. It is in the middle of the probe, not in the corner. So here in the previous technique, in plane technique, we get from the edge, and the advantage is you can see the entire length. Where here you can see this one is relatively easy to do, but you can see only the tip of the nodule. Tip of the needle.
Srinath, Srinath, can you ask the question, please? Yes. Okay, Gokul, we are done. Anything more?
Okay, so that is the end of the summary. This is a summary, sir. So if the nodule is more cystic, then it is more likely to be benign. And echogenicity, if it is bright, more chance of benign. Margins, well-defined margins, no calcifications, wider than taller, soft consistency, all are features of benign. If it is if it is mostly solid and it is having it is markedly hyperechogenistic compared to the strap muscle of the neck as well as the distant thyroid, and it is having irregular margins, punctate calcifications, taller than wider, hard consistency of the nodule, all are features of malignant nodules. So the conclusion is that the FNAC could be reserved for patients who are having thyroid score of 3 and above. Secondly, the shear wave ultrasound elastography combined with thyroid's reporting system had a good correlation with the Bethesda cytology classification. And the potential future direction is that the conventional ultrasound as with the elastography could improve your diagnostic accuracy. That's it.
Gokul, can you unshare? I just want to show one slide before we stop.
One minute. Yes.
Okay. I'm just going to share quickly one practice for everyone. Okay.
So you're muted, sir.
Yeah, we can't hear you, Krishna. Krishna, you're muted. We can't hear you.
Now?
Yes.
Okay.
Yes,
So
we can now.
Okay, so quickly look at this, everyone, just to get a practice, right? So you want to look at composition, echogenicity, shape, margin, echogenic foci. Can you see the composition is completely solid? It is not hypo in many ways. The shape is not taller than wider. The margin is very well made out. There's no echogenic foci. Can you see this? The composition is 2. The echogenicity is 1, the shape is 0, the margin is 0, the echogenic foci is 0. Total score is 3, the thyroid score is 3. The FNAC is greater than 2.5 centimeters. Here is another one. Can you see this? It is very, it is irregular. You can see that it is hypoechoic. The shape is almost rounded, but not taller than wide. The margins are not very well made. No echogenic foci. And you see what you have: composition 2, solid, echogenicity is hypoechoic, shape is 0, but the margin is 1 because we're not able to fully make it out. No echogenic profile. Thyroid score of 5, FNA greater than 1.5 centimeters. This one is even different. Again, this is the same. So the Thyroid's calculator 1 is here. Just wanted to show. So I'm just also showing how we do it. So here is our patient. This is our EMR, and you see that we have it in our EMR. And here's a Thyroid's 5 who's had, and that we have done the B4. The FNAC is B4. We actually repeated the FNAC in this patient, right? Here is somebody who, can you see, here's this patient who's had a Thyroid's 2 in 2021, but on 11/5/2022 had a Thyroid's 4. So can you see this change in the Thyroid's is one of the things that is going to make you into, the volume did not change. It's only a 2.6% increase in volume, but the Thyroid score changed. And this patient we had, this is to answer Arun's question. Can you see this? The negative predictive value of the ACR Thyroid score is 91%, correct? The specificity is reasonable, but can you see the sensitivity is the important part? And if you look at it, it's much better than the ATA and the others. And the unnecessary FNAC rates is the lowest with the ATA score, and that's really why we do it. With this, I'm going to stop, and of course, we're happy to take any questions and also answer it. I know we're a little over time, but I hope this was worth it for all of you. I want to applaud my young friend, Dr. Gokul Krishnan. I've seen him grow, and it's a matter of pride for me to be doing this. Thank you so much, Gokul.
Thank you. Thanks,
Doctor. Thanks, Dr. Bajaj, and everyone in the ITS team for this opportunity. If you have time for questions, we'll take some more. If you want to finish the quiz, we'll do it. Dr. Jiganavi, it is all yours. Dr. Neelaveni, thank you for the opportunity.
I think Ganavi running out of time.
Yes, ma'am. Thank you.
Yeah.
But if there are any questions, we can still address them. There are one or two. I think all the ones in the chat box, have they been addressed?
Yes, ma'am. The chat box we have done.
Okay, perfect.
Dr. Gokul?
Somebody, sorry, sir, can I ask a question? Okay, that's done as well. Okay.
I have a question, Dr. Gokul.
Yes, ma'am.
Yeah, your experience of inferior thyroid artery velocity in differentiating the hyperfunctioning gland versus the destructive thyroiditis.
Not really, ma'am.
Yeah.
No, I have not done doctor studies in thyroid. I don't have any experience in that.
Okay. Because it's an important tool, especially with respect to the pregnancy evaluation, where there may be difficulty, though we have traps which can be done to differentiate between the Graves versus the gestational thyrotoxicosis and all. But I think in some of the individuals where we cannot make a differentiation and where we have to go for making a decision to use the anti-thyroid medication, so inferior thyroid artery velocity, but it requires little expertise to identify the inferior or locate the inferior thyroid artery.
Actually, it's a more simpler thing to do if you have if you have the experience and if you have a good probe. Unfortunately, most of us don't use very good resolution. Just the plain vascularity and the vascular patterns there have been several publications looking at comparing radioiodine uptake versus thyroid ultrasound vascularity. And I'm sorry, at the top of my head, I'm not able to give you the name of the publication, but there are at least 6-7 publications that I have myself reviewed that actually tell us that if you have a good sonologist, they can make that difference for you in terms of thyroid artery vascularity. You don't have to search for the ITA, just do a thyroid parenchymal vascularity and its echogenicity. It gives a beautiful. We've used it also in distinguishing thyrotoxicosis from thyroiditis. I think we have some data, and hopefully once we publish it, we may be able to sort of obviate the use of uptakes for these kind of things. Any day, these are probably better than TRAB, because TRAB is still a very, very unreliable test, in my opinion. I'm sure people can disagree, but it's still a very unreliable test. For example, right now I have a patient who has an AFTN who's also TRAB positive, and then you're stuck without knowing what to do, and then ultimately we did a radioiodine ablation. But I think a TRAB is still a second test and maybe an ultrasound will again supersede this.
Thank you, sir. So I think we can take up the quiz questions.
So we need to have the analysis of the answers and the discussion in that context. Please go ahead.
Dr. Gokul, would like to
Yes.
discuss on the questions? Yeah.
Yes.
Right.
Can we have the answers, ma'am, or shall I discuss the answers now itself? That
No, we'll
percentage.
go through the slide deck again,
Okay.
and for each slide, then the answer will follow, and then you will discuss that. So you are sharing, right? Yeah.
One. Coming to the first question, what is the needle size preferable for doing thyroid ultrasound FNAC? The correct answer is 24 gauge. We prefer to use. Can you have the answers, or shall I go to the next question now?
Is there
Just to
any-
add that
Yeah,
be
any
careful
reason?
about 18 gauges. Be careful about 18 gauges because one, it's painful. The second important reason to be careful is there have been 3 reports in the literature of seeding the thyroid bed with malignancy using a smaller or larger gauge needle. So don't use it. Use a 24 gauge. Gokul, we didn't talk about it, but I think what you really need to do is you don't need a syringe. With a 24 gauge needle, you can put it in. And rotate.
Automatically it will, because of the negative pressure, it will come out, the sample will come out automatically. We don't connect the needle with the syringe actually in our practice. So automatically we can get the sample once the needle is within the correct position within the nodule. It automatically comes by probing position technique. We'll get the correct sample in the hub, the needle hub. Then we discard few drops before taking the sample to the slide.
Correct.
So this is to avoid the hemodilution, so that the RBCs, number of RBCs can mask the thyroid cells. So we need to discard few drops of blood. Then only so if we are using 18 gauge, more amount of blood will be there, and it will be inadequate for interpretation for pathology.
And you will seed it. So the other thing is that use what is called, you can either rotate the needle or you can agitate it as you do. What I do is I rotate and agitate as we go through, and it works well. When you smear it on a slide, take it up and look it up in the thing, you will be able to see specks of colloid. Now, if you see that, then you know that you don't even need a cytologist. If you see specks of colloid in it, you know it's a sample.
Adequacy.
Let's go on.
It will be a little granular also.
Go on, please. Thank you.
Second question, what is true regarding the consistency of a nodule? The correct answer is, harder the nodule, more chances of being malignant. That we already discussed. Going to the third question, how do you comment the echogenicity of this nodule? This nodule is brighter than the adjacent thyroid parenchyma. This is adjacent normal thyroid parenchyma as well as the strap muscle. So this is hyperechoic nodule. This is how we term this nodule, because it is brighter than the thyroid parenchyma as well as the strap muscle. Fourth question, the correct answer is, what is the shape of the nodule? It is taller than wider. So this nodule is taller, 1.2 centimeters, and the width is 0.8. This is taller than wider. It is growing against the tissue plane. It is more, it definitely will be hard in consistency. Okay, so this is given 3 points. Next, how do you interpret this ultrasound as? So the correct answer is pseudonodules. Here you are seeing some kind of nodular appearance, but you're not seeing the discrete wall. It is not discrete nodules. So these are all pseudonodules, which in case of thyroiditis, and people tend to mistake it for a multinodular point. Question number 6. Which of these nodules do not warrant thyroid FNAC? Option A is the correct. ACR thyroids 1 and 2 doesn't warrant FNAC. 7th question, what is the name of this artifact? It is called comet tail artifact, which we get it in a punctate echogenic foci. It is a microcalcification. Here will be 3 points for this kind of nodules. Next. 8th question, what is the name of this imaging technique? This is the elastography. For example, if you are seeing this, the correct answer is shear wave elastography. The nodule is not homogeneous. It is showing different color coding. For example, it is hard. This region is hard. This region is intermediate. This region, the lower one is the soft. So when you're doing FNAC, we need to target this hard area, not the softer areas. So for selecting the FNAC, this will be a valuable tool. For selecting the region of interest, this will be a very valuable tool. Question number 9. What are the key points in assessing the malignancy of nodule? So out of all the 4 options, I've given vascularity in all the option B, C, and D. So vascularity is not given importance in assessing the thyroid scoring. So vascularity is given here and here. So we go with composition, echogenicity, margins, calcifications, and shape. So option A is the correct answer. And what is the name of this imaging technique? This is called as micropure imaging. The correct answer is option C, micropure imaging technique. For sometimes you may have a difficulty in interpreting the microcalcifications. For example, here the background will be suppressed. It will be darkened. Only the microcalcifications will be highlighted like a starry sky pattern. Somewhat you can see the small dots, no, very bright areas. So this will suppress the normal background and it will highlight only the microcalcifications. So this is another a tool which is a software which can help you in coming to whether definitely there is a microcalcification is there or not. So these are the 10 questions and this is the answers. So that is the end of the quiz session, sir.
Lastly, just to this thing, remember that artificial intelligence is now coming in a big way. You can actually use, there's another thyroids called the AI thyroids that people are using that is going to take away people like Gokul out of business. You must find some other thing to do, Gokul. So thank you so much.
One
Go ahead.
final question to Gokul. Like,
Yes.
what is your opinion on contrast enhanced ultrasonography in the evaluation of the nodules?
Yeah, a contrast enhanced, again, it is for vascularity now. It is assessing the vascularity. Assessing, I don't have any experience. I have not done any case for contrast enhanced. But whereas we are done with the contrast for liver lesions.
Okay. I think your voice is breaking, Dr. Gokul.
See, the contrast enhanced
liver lesions, hypertrophic liver lesions.
See, the contrast enhanced ultrasonography is mostly used in looking at tumor microvascularization. I think that's something we want to remember. Having said that, if you look at the data on contrast enhancing microvascularization, it is very patchy. It is also because it is very operator dependent. Right? So while these are all mentioned in the literature, I think for all of us, the 95, 96% of them, unless you have tremendous experience in your center in doing this,
Right.
I would recommend not to do it because it only confuses the picture.
Yeah, thank you. Thank you. So, shall we have the announcement of the winners, madam?
Yes, please. Asmita?
Ganvi? Yeah.
No, Ganvi has left. She had
Okay.
she had a personal problem. She's had to leave.
Yeah.
So Arun is there with us. And Pramila is also there. Mini is there.
Okay. So winners, Dr. Shruti R. winner first, and second, Dr. Neelam Yadav, and third, Dr. R. Manoj Reddy. So congratulations to all the winners and all the participants as well.
Over to you, Arun.
Yeah, well done. Those who won the quiz, and as ma'am was saying, those who participated. I think quiz has been one of the most popular bit of our evening thyroid clinics.
Yeah.
So, ma'am, I think this brings to an end our thyroid clinics, which has been, I think, extremely popular among people who have come in. Please, we would like to remind you that all these sessions are available on our website. So please go back and check this and use it as a learning tool for, especially for the postgraduates and for, I'm sure for many of us as well. It's a very, very useful tool. So my job is first to thank both the speakers. Krishna, we have heard you many times before. We know how good you are and how you have developed your interest over the years. So thank you so much for doing your bit, and thanks to Gokul for a wonderful session. You have been very clear and concise. You have been very honest in explaining your experience as well as the limitations, and I think that's what is important in these sessions rather than the theoretical knowledge. It's for us to understand where we stand, and as you have rightly said, I mean, even tools like shear wave, I'm sure there will be more progress as time goes on. So it's important that we continue to do all these things and learn from it, and the time will come when we can do away with a lot more of the FNACs and really become more accurate. Of course, the molecular methods also are taking over. So it's a very interesting area, and thank you so much to both the speakers for having taken us through this journey. And thank you so much to Madam Dr. Nilaveni for very expertly moderating this session. And thank you once again to all those who have contributed in terms of the questions and interaction. Pramila and Sarita ma'am, is there anything you would like to add before we conclude the session?
Pramila, you're mute.
Yeah, ma'am. Dr. Arun has spoken everything. I think it was great experience for me as well, a learning experience, I should say, over all these thyroid clinics which we have organized collectively together as a team. And it was really nice and good learning for all of us on different topics concerning thyroid, because we haven't had any dedicated thyroid clinics before or topics pertaining to thyroid only, because we always used to discuss more of diabetes and other endocrinology, but thyroid was a little bit less discussed. And as Dr. Seshadri also told that our thyroid research and practice journal is there. So again, I'll request everybody to please contribute to the journal. Original articles, case reports, everything is welcome. Please contribute, because it's a journal of the Indian Thyroid Society. So please contribute, and it is online submission. Please do that. And it's a fast review. So if we make our journal better, I think that'll build up the journal, and that is what we want to do. So that's one thing which I just want to say, and I pass it on to Madam.
Thank you. So I think Arun, Pramila, Minnie, you will agree that this has been a grand finale, but only for this year. I think I'm sure we should at least try to continue it into the next year. And basically, because we have a full month of daily programs for the Thyroid Awareness Month in Jan, for which we do need a lot of preparation. So that is why I said we'll stop it in November. And in December, we'll prepare for the whole of month of January. And I'm happy to say that I think Mohan has joined us. He'll be the coordinator, and the conveners will be the same, Pramila, Arun, Minnie, and myself. So I think, thank you, Mohan, there you are. So I think, to Krishna, I think, thank you for sharing your, I think you said almost 2 decades, a little over 2 decades of experience doing ultrasounds. And fortunately, everything needs a good team. So apart from a clinician, you would need an excellent radiologist like Dr. Gokula Krishnan. Of course, you yourself are, I think, a master ultrasonologist yourself and a cytologist. So if you have all these 3 in place, so more than I think any machine, is the man or woman behind the machine that matter. And you've highlighted the fact that we don't have, so it's very difficult, I think, for us to ever be able to get those molecular markers done. I've never had it done, honestly. So I think the way you've highlighted the importance of the ultrasound as an important tool, much more than whether even how to use a shear wave elastography, even that you need specific indications for that. Even PET CT, you said, MRI, it's not required. A good ultrasonologist with good cytology is what we actually need. So I think, Nilaveni, you've been an excellent moderator. And thank you, Arun, for chairing this session. Ganvi has had to leave, but she's coordinated, like you said in the beginning, she's coordinated all the sessions very well. And believe you me, it is tough. It is tough. to stick to timelines and get everything in place. Thank you, Pramila, Mini. Thank you, Asmita from the digital team. And I think Meenakshi is there. Congratulations to all the winners of the quiz. And do look out for subsequent announcements. It will be there on the website. Like Arun said, all these clinics are and will stay on the website. And hopefully we should be able to continue them, possibly from February onwards. Because January, we're really going to be busy the way we have a jam-packed month planned ahead. So join us again, but that's more for public awareness. That is something we've been lacking. So we've done a lot for the physicians. So I thought we must focus on public awareness. Thank you. Thank you so
Thank
much.
you, madam.
Thank you, Krishna.
Good night, everyone. Good night, everyone. Thank you.
Thank you,
Night.
Neela.
Yeah, good night,
Thank
everyone.
Thank you, ma'am.
Good night.